Good morning, everyone. Welcome to another episode of Three Plastic Surgeons and a Microphone. I am Sam Jejurikar from Dallas, Texas, and as always, I'm joined by Dr. Sam Rhee from Paramus, New Jersey. He's at Bergen Cosmetic, and also by Dr. Salvatore Pacella from La Jolla, California. He is at San Diego Plastic Surgeon. Good morning, gentlemen.
Morning.
Good morning.
Well, today, rather than engage in small talk, I'm just going to jump straight into the meat of it. We're going to be talking about a very exciting topic, which is festoons and malar bags. And most of our audience has no idea what I just said. But basically, this is complicated lower eyelid surgery. Before we get into this, though, I'm going to read our usual disclaimer. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something you see in this show. So Dr. Pacella happens to be an international expert on eyelid surgery, so we're happy to let him lead this conversation today. So my first question to you, Sal, is what are festoons and malar bags?
Great question. So obviously very, very problematic issues in and around the eye. And many times these things are congenital, many times they're age-related. And the reason we're sort of doing a podcast on this is something we're seeing with increasing frequency in the press and patients coming in and asking for it. And like anything, if there was an easy treatment for it, it wouldn't be so much of an issue. The thing that makes these very difficult is there's no great treatment for this. And so what I've sort of put together here is a little bit of a discussion about this and kind of my approach to this and modest success with it. Okay, so I'm going to share my screen here. Okay, perfect. Okay, so the interesting thing about this part of the face, the anatomy, is this is a unique anatomic construct in our face. Okay, so if you see this gent here, he's got these sort of bags to his lower eyelid. We'll call those the lid or palpebral bags. And then the festoon or malar bag. A festoon is sort of when the skin is a little bit looser. A malar bag is when it's collected with a bunch of kind of swelling or edema. And in fact, I'm going to use those two terms interchangeably. Some authors may disagree with me on that, but just for simplistic sake, we're going to kind of use those interchangeably. So if you look at on the left side here, this is an anatomic drawing of the facial skeleton. And what I want to point out is this area right here. Okay. So the malar bag or festoon is a three-dimensional box, essentially, of ligaments and structure in the middle of the face. The top of the box is caused by a ligament is made by a ligament called the orbital malar ligament. And then the bottom of the box is caused by a ligament or is made by a ligament called the zygomatic cutaneous ligament. These ligaments go from all the way to the bone to all the way to the surface of the skin. So think about this like two shelves in a bookshelf, okay? And in that bookshelf is this area called the prezygomatic space. And so this is notoriously an area that doesn't drain very well, and it maintains fluid in the face. And that's truly what causes malar bags. And I'm going to guess both you guys are big dudes when it comes to soft tissue fillers. How many times do you have patients come in and say, hey, I hate this bag underneath my eye. I want some filler for this?
All the time.
Often. Yeah, very often.
Right. And so the issue with injecting fillers, and, I would say that, we see a lot of non-surgical providers doing fillers. Some are better than others. We see a lot of nurse practitioners, PAs injecting fillers. And notoriously what I see sometimes is that when filler gets injected into this prezygomatic space, it stays there. And that festoon or malar bag will actually look a lot worse afterwards. So big caution for our patients here. Injecting in and around this area can be very problematic if you get it in the right space. Comments on that, gents?
Absolutely. This is a very sensitive and tricky area to treat, and it does take experience to know what you're doing with it.
Yeah, I mean, because I loved your analogy of the two bookshelves. If you inject in the wrong place, and you end up injecting so that it's trapped between those bookshelves, you can actually exacerbate the problem as opposed to improving it.
Mhm.
And I've seen many patients come in who have wanted their filler dissolved when they were injected somewhere else, try to make this in an attempt to make this better.
So I've spoke on this topic quite a few times, both in the U.S. and out of country, and I did publish a few discussions on this topic for malar edema, mounds, and festoons. So something I feel fairly comfortable. And the key here is surgical treatment is not perfect, but it really sometimes is the only real option when it comes to treating this effectively. And so I'm going to show you guys a little operative video here. So that the key here is, let's just go back to this here. So the key is when we are treating this area, we have to understand that that bookshelf goes all the way from the skin to the base of the bone. So you have to, as the surgeon, independently remove that ligament both in the level above the bone and in the level underneath the skin. So this orbital malar ligament has to be taken down at the level of the bone, going all the way deep into the midface, and at the level of the skin. And what the viewers may not necessarily gather from this is just how challenging sometimes this dissection and this surgery is. Gents, thoughts on that?
It sounds like that would cause a ton of postoperative swelling. I totally
Tremendous
understand why you would need to do that, but how long do you tell your patients it's going to take for their swelling to go away?
Sometimes 6 months. I mean, it is a huge challenge. In fact, I have a patient I'm dealing with that I've treated about 3 months ago, and we still have some residual swelling in place. And but we know this ahead of time going in. So the key here is both the surgeon and the patient have to be committed to this operation.
And do you do anything postoperatively in terms of steroid injections or oral steroids to try to help it go away faster, or you just sort of let time do its thing?
No, you sort of let time do its things. And that's an interesting concept here as to why the swelling persists for so long. So if you think about it, the way the anatomy of the face is, there are two major drainage channels that occur. There's one that's medially right near the nasolabial fold here, and another one near the malar mound right here. And so those two anatomic channels that drain postoperative fluid are disrupted from all of the surgery. So it takes time for your body to drain this stuff, and it's going to be dependently drained into the face. And that pulls a tremendous amount of fluid in and around the eyelid. It pulls it in the midface and in the cheek. So it just takes a tremendous amount of time for this to go away. Much like, say, if you sprained your ankle, right? All of that swelling is dependent. It has to go back up towards your thigh and into your abdomen to get away from your body. Same sort of thing here. It's a dependent swelling that has to sort of find its way back to the veins of your face. So very challenging. So let's kind of go into a little bit of the dissection here. So here is a dissection of doing, this is called a skin muscle flap here. So I'm going underneath the muscle and I'm dividing at the level of the musculature and about to divide this ligament. So this ligament is really deep into the face. And so here we are, and that's right now I'm dividing what's called the orbital malar ligament. So that's right at the level of the orbital rim, and you can see a nice layer of fat underneath here. Okay, so this is the extent of the dissection superiorly. But we have to get this dissection even further down into the face, and that's what causes all the swelling. So here's an example here of this gentleman. We've done a malar bag / festoon resection, doing that dual plane approach to the eyelid. So you can see him before and after. Now, clearly not completely ablated, but certainly improved. And the key here is all of these patients that have these deformities sometimes, most of them have prominent eyes. And in fact, that's the reason why we're in this situation sometimes is if you think about this, the skin and the soft tissue hanging off of the orbital rim, because you've lost volume there, that by definition makes your eye very prominent. So this is him before and after. I think we've got a really good treatment of this. And it's not so done to the point where he looks unnatural, but it just looks like that festoon and that malar bag is successfully treated.
It's a really hard hard operation. I don't think viewers necessarily realize just how difficult this can be to fix. Just a couple more questions. One, so you're dividing orbital malar ligament, both deep and superficial. Are you doing the same with the zygomatico-cutaneous ligament as well?
Yes.
And are you doing that all through the eyelid?
So it depends. If we go, there's really two approaches to go. One, you can go through the eyelid, what we call a transconjunctival approach, so inside the eyelid. The other is what we call a transcutaneous approach, so on top of the eyelid, just underneath the lash line. In general, the majority of the time I do this, it's underneath the lash line. The reason being is, in order to bring this tissue up very higher, we have to do it in such a way that we're going to reposition all this tissue, and you can't necessarily do that through the inside of the eyelid.
So given that everything goes from a superior approach and there's so much swelling, what kind of steps are you taking post-operatively to support the eyelid position so that you don't get malposition of your lower eyelid afterwards? It looks like you've done either a canthoplasty on this patient. Is that accurate? Okay.
Yeah, so almost routinely, I'll do a canthoplasty versus a canthopexy. So the difference between those two is removing a little bit of lower eyelid tissue in a canthoplasty, whereas a canthopexy means we're just putting a suture in to support it. And so the tightening of the lower eyelid is an absolutely 100% critical concept to this. You have to suspend that lower eyelid to the corner of the eye, what we call the lateral canthus, to the bone, and you have to do it tightly. Otherwise, that eyelid will pull down. I have a little saying in eyelid surgery: the lower eyelid only wants to go one place, that's down. And so you have to really pay attention to canthal fixation. There are a lot of surgeons out there that do fairly minimally invasive eyelid surgery that don't believe in canthal fixation. And I would caution them when you do an extensive malar bag or festoon resection like this.
I will have to say, when I first started doing these, I did not incompletely cleared the ligament off the bone, and I would get recurrence for my first couple of cases. I will say, even though I've done a craniofacial fellowship, and I felt very comfortable doing lower lid fixations, like that was really part and parcel of a lot of what we did. That's bread and butter craniofacial surgery. The Codner videos, the way he does his transcutaneous lower blephs, were probably the best thing I ever watched and learned from in order to clear the ligaments, both under the skin and on top of the bone, how to fixate that lower lid properly, not pull too hard and make it look pulled back, but to provide that support and still provide a natural eye shape. Like, I have to say that those are still some I would recommend for anyone. Like, those are some of the best videos out there that are publicly available under PRS that sort of help me figure out how to do this properly. And for a lot of these, I still have to do it transcutaneous just because I need that exposure in order to clear the ligaments properly. And if you look at this picture, you can see it's well done because the eyelid shape, it's not pulled back. He doesn't have a really narrow palpebral like opening on his eye. Like, it looks very natural. If anything, it looks a little bit more naturally shaped, the lower eyelid, than it did before. So that to me was so important to learn when I first started doing these.
And who Dr. Rhee is referring to is, I think we mentioned in the podcast before, Dr. Mark Codner, my very, very close friend and mentor, who I did my fellowship in Atlanta with, who passed away tragically a couple of years ago, but just an absolute inspiration for this type of operation. I've collaborated with him professionally many times, and a good friend. He's sorely missed. Let's kind of move on to another case here. So this is another example of a very, very extensive malar bag / festoon combination. As you can see in this gal, also has quite a bit of upper eyelid swelling and upper eyelid skin and brow descent here. So she had a direct brow lift, so a subcutaneous brow lift, in addition to an upper lid removal / blepharoplasty, and exactly that procedure of the festoon resection, malar bag resection that I described. 2 divisions of the ligaments, the orbital malar ligament and the zygomatic cutaneous ligament, and an extensive subcutaneous or below the skin dissection. And as you can see here, she almost looks like a different person. Those bags are completely gone. We have maintained the eye shape. And, this is not without significant patient cost here, meaning cost from the standpoint of recovery. It took at least 6 months to get this swelling under control. And, it is absolutely an operation you cannot take lightly as a patient or a surgeon. It's not your grandmother's transcutaneous or transconjunctival blepharoplastic bag removal. So
it's amazing. I mean, that looks like her grandmother in the before picture. And then that, it doesn't even look, you're right. It's not even the same person.
Yeah, that's a fantastic result. That's a very hard to achieve a result like that. Not a lot of people could get a result like that, actually. So
only a few.
Maybe Mark, maybe Henry.
Maybe Henry.
Another example here. So you can see this gal here. So now with all disclosure here, this gal had a complete facial rejuvenation. Brow, upper lids, lower lids, festoon bags, facelift, fat transfer, and chin implant. Okay. And so the key here is focusing on those lower lids. So if you see here, the facelift helped to support this quite a bit, which is fantastic. But just look at how smooth the skin is now compared to beforehand. And, getting that shape of that eyelid, I think, is really critical. That canthal suspension, canthal support is key. But you really have to dissect all the way down into the mid-cheek. This goes very well. You get some economies of scale with healing when this is coupled with a deep plane facelift. If you look at her side view here, or the oblique view here, this chin implant really helps quite a bit with her facial performance.
Let me ask you this. Did you do this all in one shot, and how long did that case take, and what was the order? And what was the order in which you did the procedures?
So I will say that, I early in my career was pretty hesitant to do all of this at once just because it would take a significant amount of time. But I think I've figured out a way to kind of do this rather efficiently. So I would say that if we were to do a full facial rejuvenation, brow, quad bleph, facelift, fat transfer, it probably takes me a good 6.5 hours to do, 6 to 6.5. The key is I start with I start from top to bottom. So I will do the dissection of the brow. And again, I think we've talked about this before. I've almost completely switched my practice from doing endoscopic brows to doing subcutaneous brow lifts. I think the longevity is so much better. And so subcutaneous brow lift doesn't take a tremendous amount of time. I do the initial dissection down to the orbital rim. I then temporarily suspend the brow with staples, and that allows me to sort of set the brow position to prep for the blepharoplasty. Then I'll do the upper lids, then I'll do the lower lids, and then I'll go open up that same incision and connect it to my facelift incision from the brow. And that way, at the end of the case, once I'm done with the dissection of the facelift, I can support the brow position in the planned area that I did before.
Wow.
Yeah, I mean that makes a lot of sense. I agree with you about subcutaneous brow lifts as well. Well, just your improvement in her wrinkles and her forehead is amazing.
Yeah, fun operation, takes a tremendous amount of time, a lot of swelling, a lot of patient encouragement, and they have to really be kind of engaged with the process. This is not a quick fix that you're going to do before your son's wedding kind of thing,
Yeah, those are amazing results. Again, they're dramatic changes, and they're dramatic preoperative photos as well. So luckily not everyone needs this, but in cases like this, I know that now that I'm going to send them to Dr. Pacella. Because I think I'd have a hard time dealing with 6 months of postoperative swelling and all the hand holding that goes on with that.
Oops, lost my camera.
Well, anything else you want to share with us, Dr. Pacella?
That's it, my friend.
All right. Well, as always, thanks to everyone for tuning in, and we'll see you on the next episode.